Yes, thank you, Marcin, and welcome everybody to the Thursday, September 22 Connecticut Health Insurance Exchange Health Equity Outreach and Consumer Experience Advisory Committee special meeting, our first meeting. I do first want to apologize. I meant to be there in person, but I'm in the Zoom frame of mind and I forgot that we were in the beautiful Connecticut Historical Society auditoriums. And then by the time I remembered, it was too late. So my apologies to those who are in person. I would have liked to meet you in person, but it's great to have everybody here virtually also. So Marcin, do we need to do a roll call or anything of that nature before we get rolling?
Mr. Chair, just for the public attendance, for the attendance records.
Okay.
Theodore Doolittle.
Here.
Kevin Galvin. CC Woods.
Here.
Aaron Siegel.
Here.
Thank you. Giselle Carolina McDonald.
Here.
Thank you. Leslie Greer.
Here.
Deb Pollen.
Here.
Thank you. Sheldon Tubman.
Here.
Thank you. And Jared O'Sullivan.
Here.
Thank you.
Great, thank you, Marcin. So the we have introductions, call to order and introductions. So let me just start, and I will ask folks to give a brief introduction of themselves, just in the order I see you on the screen. So my name is Ted Doolittle. I'm the head of the State Office of the Healthcare Advocate. We are an independent state agency and designated by statute to have a seat on the Access Health CT board. We have a team of nurses, paralegals, attorneys, and others whose main bread and butter business is to represent folks who are fighting with their health insurance coverage, be it public or private. So if you anything ranging from that niggling situation where you can't get your insurance company to change your address on up to a family that has a complex medical condition that stretches out over many years, and they have multiple denials and anything in between. So anything where you're struggling to achieve health coverage and access, that's where OHA lives, the Office of the Healthcare Advocate. So that's a little bit about me and about OHA. Let's go ahead, just in the order I see you on the screen. Carlotta.
Thank you, Ted. Good morning, everyone. I'm Giselle Carlota McDonald. I'm the Executive Director of Project Access New Haven. We work to increase access to medical care and services for the Greater New Haven residents, and we do so by coordinated donated care for patients that are uninsured and have urgent specialty care needs. As I mentioned, uninsured, we have it's also part of our mission to increase access to insurance. So we have worked with Access Health for many years to also help those that may qualify for insurance. I'm very happy to join this great group, and thank you for having me.
Thanks, Carlotta. Next, I see Leslie, please.
Hi, I'm Leslie Greer. I work with the Office of Health Strategy. I am a Consumer of Information representative. I'm also a outreach coordinator. I am very much involved with the with our community health workers. I also do a lot of work with hospital billing. I do a lot of work with the outreach in our office, outreach engagements in our office. And our office does a lot of work with prescription drugs and helping to get those lowered. And we do a lot of advocating for healthcare, and we do certificate of need, hospital. We regulate the hospitals here in Connecticut and the certificate of need program. And we also do a lot of data collecting, coverage, and what else do we do? Let's see, there's so many different little avenues for our office. Let's see. I can't think of anything else, but that's a lot of the things that we do. So very happy to be here. So
Thanks, Leslie. Next up, I see Cece, please.
Good morning. I'm Cece Woods. I am a retiree from Senate Democrats of many years. I'm a longtime board member, and I'm extremely committed over the years to consumer involvement in Access Health Connecticut. I want to thank James for reinvigorating this committee, and I'm happy that some of the older members have returned. And I wanted to thank Ted for taking on this leadership role. I'm a big fan of the Broker Academy, and we'll be talking about some of that today. And I'd also like to mention Alta Lash, who's now deceased, but served on this original committee for so many years. And I'd just like to thank her publicly, and hopefully her family will know about this. We appreciate all the work that she did, and some of you who were involved with her will remember her. So thank you.
Great, Cece. Thank you. Karen, please go ahead.
Hi, everyone. I'm Karen Siegel. I use she, her pronouns, and I'm the Director of Policy at Health Equity Solutions. We're a statewide organization that does advocacy and outreach and education related to health equity with a race forward definition of equity. And in the private health insurance space, two of the things that I think are relevant here are that I serve as a consumer liaison to the National Association of Insurance Commissioners, and also we do consulting work with state health and value strategies to provide technical assistance to state-based marketplaces and Medicaid programs across the U.S. So we've done some work recently on state-based marketplace benefit design and other pieces like that. Excited to be here.
Thanks, Karen. Next, I see Sheldon. Sheldon, please.
Good morning, everybody. I am, my title is litigation attorney at Disability Rights Connecticut, but of more relevance here, perhaps, for 30 years, I worked at New Haven Legal Assistance, where I was basically a Medicaid advocate for all people, all kinds of folks, but specifically in the Medicaid area. And at Disability Rights, it's more broad and more narrow. It's more narrow in that we only represent people with disabilities, all kinds of disabilities, but that's really the focus. However, it's not just the Medicaid program. So access to health care under the exchange and otherwise is also of concern to the extent folks have disabilities, which is sort of the key to getting our services. And for healthcare, the three big areas we're involved in are, the eligibility questions, the services, what services you actually get, both the benefit design, but also, access to providers, are providers available? And lastly, the delivery model, and we're particularly concerned about preserving access to healthcare as various payment reform models are discussed that might put financial risk on providers. That's sort of the full range of things that I've been working on in the healthcare area. I hope some of that is relevant to the discussion of this group. And I'm sorry, I should have said I was on the group before. It's good to be back. Thank you for having me.
Good to have you, Sheldon. So I think that I want the staff who are on to introduce themselves in a moment. But first, Marcin, are there any members in the room at the Historical Society?
Yes, Mr. Chair.
Yes.
This is Gerardo Sullivan. I'm the Director of Consumer Affairs for the State of Connecticut Insurance Department. We handle all lines of insurance, not just health insurance. On the health insurance side, we regulate fully insured commercial insurance, which would be the individual with small group plans on the exchange. We regulate to make sure that Connecticut insurance statutes and regulations are followed. Our area handles complaints, inquiries. We are charged by statute to educate the public on insurance. Our complaints work as real-time information to see how the marketplace is performing, and we can take action based on those complaints along with our market conduct division. to correct any wrongdoings immediately.
And good morning, everybody. I'm Deb Poland. I'm the Executive Director of the Connecticut Association for Community Action, or CAFCA. And we're the state association that works with Connecticut's 9 community action agencies, which are the anti-poverty agencies that work with about 200,000 people across Connecticut each year, including a variety of different programs. Some of the community action agencies have served as navigators for Access Health. And I am pleased to be back on this committee as it reinvigorates itself and back with some old and new friends to help bring the consumer voice into the experience.
Any other members in the room there, Marcy?
No, Mr. Chair, there are no additional members in the room.
Okay, great. Now, I know there's a few staffers on, including yourself, Marcin. I know you did a brief introduction. If you could just introduce yourself again to the committee members, and then I'll ask Tony and Janelle to, and anybody else who's in the room in terms of staff to do the same.
Hello, everyone. My name is Marcin Lechowski. I work as a governance specialist at Access Health CT, and I'm assisting with putting together a board of directors meeting and other standing committee meetings, as well as advisory committee meetings. Thank you.
So if you haven't made Marcin's acquaintance as a member of this committee, you will soon, and you'll find him to be incredibly responsive and super organized, and we're lucky to have him. I see Tony is on the line. Tony, would you like to introduce yourself?
Thank you, Ted. Yes, this is Tony Crow. I'm the Chief Operating Officer at Access Health Connecticut.
Great, and I see Janelle.
Good morning, folks. Janelle Maloney, IT Director over at Access Health.
Marcin, any other staff in the room at the Historical Society?
Yes, Mr. Chair, and obviously Mr. James Michel, CEO, and we can start introducing around the table.
Sure. Thank you, Ted. Thank you much, Ted. James Michel, I'm CEO for Access Health Connecticut. Let me start by saying that I'm looking forward to engaging with this committee. We have been doing a lot of work to improve the quality of health for the residents of the state of Connecticut, especially those who are historically underrepresented throughout our history. So we look forward to really making a market improvement across the state of Connecticut. And you're going to hear some updates today, some steps that we have been taking to start that process. And we look forward to having every member of this committee engage with us and provide us with guidance, because many of you are very close to the communities that we serve. So your input will be of interest to us as we develop our strategies to move forward. But we do have a very engaging presentation for you today. Again, I want to stress this is our first meeting, so everything we present is for your information. We look forward to your provided with input to revise and adjust accordingly. Thank you.
All right. Good morning, everyone. My name is Tammy Hendricks. I'm the Director of Health Equity and Outreach here at Access Health. Really, my team is responsible for all the statewide outreach, working with navigators, organizing in-person educational events and enrollment events throughout the state. And I will also be the lead for this committee, the senior leadership here. And I'm excited to be here and to meet this new committee and re-energize this committee with a new focus on health equity.
Good morning, everyone. I'm Glenn Jurgen. I'm the Director of Human Resources at Access Health Connecticut.
Good morning, everybody. My name is John Carbone. I'm the Director of Small Group and Product Development at Access Health Connecticut.
Morning, everyone. Susan Ridgeby. I'm the Director of Legal and Governmental Affairs at Access Health Connecticut, and handle legal and policy issues with government, and then also extra plan. Those are some things that we're actually going to talk to you about today.
So Ted, this concludes the staff that are present
Excellent.
this morning.
Thanks, James, and thanks to everybody, Tammy, and all the team that helped put together this meeting. It's wonderful for this committee to be reinvigorated, and I look forward to working with everybody on it. That brings us to item B, public comment. Marcin, do we have public comment?
Mr. Chair, there is no public comment.
Okay, so that brings us to the mission and vision of the committee. Tammy, is that something you wanted to take?
Yes, it is. And if we don't mind going back to the agenda, just like to go through the items, if that's okay with everyone.
Sure.
Okay, great. So we have a lot to discuss today. I just wanted to run through it with everyone. First, we'll give an overview of the mission and vision for Access Health, which was recently updated. We'll talk about the important steps that we took as an organization to get here. We did an extensive study. We established the Health Equity and Outreach Department, which then led to the re-energizing and reinvigorating of this new committee. I'll give an overview of the Health Equity and Outreach team, what we've accomplished this year, the new broker academy that was launched, and we'll for what I hope we can focus on as a committee as we continue Access Health on the path to health equity and reducing health disparities. So we've gotten some really good feedback so far. Thank you, Ted, for reaching out to all the members. I welcome the feedback and suggestions as we and create a strategic plan. So nothing is set in stone right now, but I'm looking forward to working with you all on refining these goals. Then we'll have Susan talk about the essential community providers requirements for our plans. And that's really helping us in our mission to reduce health disparities. And she'll also go over the public health emergency and covered Connecticut program. And then we'll wrap up the meeting and open it up for discussion.
But I would encourage, if you have any questions at all during any of the discussion, just stop us and ask any questions. You don't have to wait till the meeting to ask any questions.
Absolutely. So we have some new members here. I know there are some legacy members on this committee, but just to start with the basics, Access Health is Connecticut's official health insurance marketplace. But what's important is we are the only place that individuals can come and qualify for financial help to lower their health insurance costs. So our organization, our vision is to provide Connecticut residents with access to the most equitable, simple, and affordable health insurance. And our mission is to decrease the number of uninsured residents, improve the quality of health care, reduce health disparities through an innovative, competitive marketplace that empowers consumers to choose the health coverage that gives them the best value. So, right now we have a more strategic focus on health equity, improving the access to health insurance throughout the state, but especially in those hard to reach communities with higher uninsured rates. So we recognize that it will take a different approach to make an impact in these areas. So we did a lot of homework, right, before developing any kind of plans. So we'd like to talk about first the significant study that we did on health disparities. All right, we needed to learn about the issues. We needed to know where the issues were and how we fit in and how we could make a difference. We can move on to the next slide. So there was some good news and bad news that came out of the study and as we were doing research. The good news is Connecticut ranks very high in terms of health and wealth, right? We also have a fairly low uninsured rate overall. But unfortunately, despite all of those good attributes, the study found that there were significant health and income disparities in communities, which many of you are aware of. But particularly in minority communities. We could go on to the next slide, Martin. So we won't go through the entire study today, but I've included this comparison that really sums up the study very well. And it really gives us a good visual of what's happening in some of the communities. And I'm sorry I had to chop it up to fit it on the screen. But this comparison outlines two hypothetical kids. Really, all of the data is based on real data. So we have Tyler, who is white from West Hartford, and we have Marcus, who is Black from Hartford. And, you know, even though they're miles apart, Marcus's life expectancy is almost 20 years less than Tyler's. And this is really due to, you know, a lot of issues, but primarily the lack of access to health insurance and poverty, huge drivers, right? Health and income disparities are huge drivers. And Mark experiences many of these, and other minorities do as well. Many minorities do as well. So all of these factors ultimately leads to Marcus's early death at the age of 68.9 years old. Correct. And then Tyler lives well into his 80s, passing away at 86 years old. So really huge difference here in life expectancy. And that's really what has driven us to make the changes within Access Health and adding more focus on health equity.
The only thing I would add is that Connecticut, you know, our wealth in quality of health is among the best in the country. But the health disparities, we are at the bottom 10 in the country. Right. So over the years, it's getting worse every year. So it's incumbent upon us to take action to address it. And again, the biggest driver is poverty. That's the biggest driver, right? Then you lay on top of that the racial issues, right? The inherent racial issues, and not necessarily about the healthcare insurance system, but more about healthcare, the healthcare delivery system, doctors, and nurses, and hospitals, and how the study indicated that a Black person or Latino person shows up with an illness, diabetes, heart condition, and a white person shows up with the exact same symptoms. They are more likely to get different service simply because of how the doctors view them. And doctors, it's not just white doctors, all doctors make assumptions about them, and that drives how they treat it. So there's a lot to do in that space. And within, I think health equity and outreach, Tammy heads up, is driving those changes that we can make a difference in their lives, and mostly through education, giving access. So there's a lot to be done, and we have started that work, and we hope with your guidance and your encouragement that we will make a difference. We have started making a difference. The data also told us that one of the drivers of health disparities is lack of information, lack of access to knowledgeable folks in their own communities, people that trust, they know. And this that was the genesis for the Broker Academy. There's a dearth of Black and brown brokers in those communities that are impacted most. So this is how we started the process of creating a Broker Academy. How do we get licensed, knowledgeable folks in those communities that live in those communities, so they become a resource for those communities. So when people have a question, they have somebody in the church, in the barbershop, the neighbor that they could call to help guide them towards the right results for themselves and their families. So again, we'll get into that more as we move through the presentation. But I just want to add some context around that. Connecticut, while we are wealthiest, healthiest, but we are also at the bottom when it comes to health disparities, not just in health, but education, income, across the board. Thank you.
Thank you, James. So ultimately, the study laid the foundation for us, and Martin, we can go to the next slide. It really laid the foundation for us to take more concrete steps towards our mission of reducing health disparities. So we are so committed that the Health Equity and Outreach Department was established, which is why I'm here. And the department is only about a year old, but we've done a tremendous amount of work within this past year. There was also a health equity webpage that was created, and that has our study. It has a short video about health disparities, feedback from real people who are impacted by it. And, you know, we really thought it was important to have a place that people can have access to this study, to be able to read it, to share it, and really just understand what is happening in many communities throughout Connecticut. So I encourage you all to visit the health equity page for more information. It will have everything that was presented today and more, but it's just a really good place for us to have the study. We also, on the health equity page, have a contact box where organizations can leave their contact information if they want us to collaborate with us, or if they want us to get more involved with their efforts. So it's a really great place. We've gotten a lot of good organizations go through, leave information, and it's been very engaging so far. So lots of great things in the health equity space. We have the department, we have a lot of outreach, we have the web page. On to the next. So the Health Equity and Outreach Department, here's a broad overview of the goals that we have for this year. And of course, each team member then creates individual goals to support these. But first and foremost, we will continue to support and promote initiatives aimed at reducing health disparities. So right now we are really focused on the Broker Academy, but there are other initiatives that will be coming soon. Again, our ties to the community and to community organizations is really what's driving the success of these programs, especially the Broker Academy. So outreach plays a huge role for these initiatives. Plan on conducting more targeted outreach to expand partnerships, but we really want to focus on more community organizations that provide healthcare services, assistance, and information, right? Important information for underserved groups and individuals. And this is so important because consumers can get other needs met while they go to these organizations, and they can get enrolled, right? So from a health equity perspective, meeting people where they are and getting them the help that they need, right? Whether that's housing assistance, energy assistance, but also being able to get enrolled for health insurance. And this is why our navigators play such an important role here at Access Health. We also want to continue to promote our CAC program, our Certified Application Counselors program to qualified organizations. This year, we're really focusing on engaging more with hospitals and health centers. We really need to make sure we have proper CAC coverage throughout the state. And that's a really big push for us, especially with the new program, Covered Connecticut, with the PHE unwinding. There's a lot of information, and we want to make sure that all consumers have access to this information and can be enrolled as well.
So can you give a little context of what is CAC and what they do?
Sure.
And how do they help people get access?
Sure. So CACs is a Certified Application Counselors program. We actually train organizations that fits the qualified organization list that we have. And we train their employees to be able to enroll folks into health insurance. So the benefits with that is consumers are able to get the help that they need, take advantage of the services programs that are offered at these organizations, but they can also get enrolled in health insurance as well, and train employees to enroll. And these community organizations are all over the state. We have a lot of our CACs are actually a part of the CHC, at the community health centers. I'm sorry, I'm losing my mind. So we have other CACs located in various community organizations throughout the state.
So the intent is if someone shows up at a hospital or at a health center without health insurance, someone is there to enroll them in health insurance, whether they get Medicaid or QHP, so that that concern about cost could be removed, and that's just to be removed from their experience while they get healthcare. That's the intent. So we want to blanket the entire state, every hospital every health center to have someone, at least one or two person that to enroll anyone who shows up without health insurance. That's the objective.
And we've also added some governmental organizations as well, like the public health department,
Yeah.
various
Yes.
communities.
And
you
cities.
know, I think we've worked with judicial, you know, for people coming out of incarceration to help them bridge that gap.
Yes. Yep. Thank you. Thank you. And finally, this is going to be an ongoing goal for us, but really working to update the New Health Equity webpage, making it more engaging, educational for consumers and our community partners as well. So we really want to encourage people to collaborate with us and vice versa. So we will continue to work on that page, make it more educational, and getting people there to see all the great work that we're doing, really. On to the next slide. So what we've accomplished so far, really, it's been a busy year for us. Not only was the department established, but we expanded it. We added 2 new members to our outreach team. And with the growth of that team, I also integrated a new contact management tool, really allowing me to run reports, see what partners we're engaging with, what zip codes that we have targeted for that month. And it was also really important for me to see what partners we needed to reach out to a little bit more, right? So I was able to get a lot of information, a lot of data, and this tool is really helpful for us to have more targeted outreach, which is the goal here. This year, more than ever, it was really important for us to expand the Navigator program. We have 4 new navigators, which we're very excited about, 6 locations. And, you know, navigators serve a really important purpose for our outreach, right? So they offer programs and services, but also they have PACs there to enroll folks as they come in and get the help that they need. And this is year round. So huge benefit there. We've also established this committee to help us continue our focus on health equity. And finally, we launched the Broker Academy, which was an organization-wide effort and really engaging, really fun. The year flew by as we stood this program up, but we got the communities engaged. We got the legislative community engaged with this program to support us. So I'll get into more details on the next slide. So amongst all the issues that we found, going back to the study before I get into the program details, you know, we found that there's an overarching issue of the lack of trust, which James touched on, right, between the healthcare system and minorities. And that often prevents them from getting the help and the care that they need. So, you know, and I think a lot of us have seen that mistrust during the beginning of the pandemic with vaccine intake for minorities communities. So while developing the Broker Academy, we really focus on that lack of trust that exists. And how do we get these communities timely information, right? How do we get them more education on health insurance so they can better understand it? But also, how do we provide job opportunities to uplift these communities? And we know poverty is a huge driver for health disparities. So all of these elements, as James mentioned before, really led to the creation of the Broker Academy. So the Broker Academy, in short, is a program specifically created for individuals who live and work in underserved communities in Connecticut. So this program really guides students through the process of becoming a licensed broker, and every step of the way, we help these students through training, through mentorship. We gave students a laptop to get them started, right? We set up a mentorship portion of the program. We recruited experienced brokers to help these students get hands-on experience, which was very important for the program. So not only did we want them to be trained, but we wanted them to be successful after completing the program as well. But what makes this program really unique is that we recruited local residents local residents that are already living and working in these hard to reach communities. So that way, when they become licensed, they can easily connect and build that trust with people in their communities. So our first class was just this past June. We held it at community colleges throughout the state. So we had a class in Housatonic Community College in Bridgeport, Capital Community College in Hartford, and Gateway Community College in New Haven. And so we had 71 students pass the training class, which is a prerequisite to then sit for the state exam. And so far, we've had 30 students pass the state exam, and they're entering the mentorship portion of the program right now and getting their license. So really, that's 30 new brokers for this open enrollment. 30 new brokers that are in underserved areas that we need to get to. So it's really exciting for us. We removed the barriers for these students to get into the field and provided resources along the way. So ultimately, the goal here was to diversify and be in those hard to reach communities, and these folks are doing that.
Can I ask a question about that?
Sure.
I think this is a great program. Do you have data on the demographics of the students who started the program and those who have passed the exam?
Yes, I do. And actually, yes, sure. So
I guess I swear I didn't.
Yeah, I knew it was coming.
I held up in advance. I was going to ask.
Most of them were women.
Yeah.
Awesome.
Same housing were women, and we were very pleased to see that. They tend to be more stable and more focused, and we were very happy to see that. And this has been a joy for us to do because it's helping us to hit all the marks. Number one is we're providing trained, licensed individuals from those communities that we know are hard hit by for a variety of issues. And the biggest one is poverty. The next biggest one, just lack of access to timely information so they can make decisions for themselves and their families. So they're going to have that access from these brokers. And also the other benefit is the economic development opportunity for these folks to earn a very good living. It's just class itself, but if they want to do other things as well to leverage their license, they could earn even more money. And if they get into the Medicare Advantage space and other health insurance product, and also as well as life insurance. So we think that the opportunities are endless for these folks, and the fact that these women who are engaged, eager to learn and grow, very trusted in their own communities that they're part of, really gives us a good shot of making a difference in the community.
Thank you, John, for having these stats up and ready for me. So of the 71 students, we'll start with Bridgeport. Bridgeport was 85% female, 15% male, 57% identified as Black, 28% Hispanic. New Haven, we had six.
Excuse me, Tammy, are you reading from a slide? Because my slide still is on number 10. Is that where it's supposed to be?
No, I actually didn't include the stats on these.
Oh, gotcha. Okay.
Yep. So, but we'll definitely send these out, these stats out for everyone. In New Haven, we had 64% female, 29% male, 47% identified as Hispanic, 30% Black, 5% Asian. For the Hartford class, we had 75% female, 25% male, 75% identified as Black, 12% Hispanic, 10% white, and 3% Asian. So really, really good mix.
Great. And then, sorry, is it okay to ask one more question?
Sure.
And so after they pass the state exam, what happens? Like, how do they get set up to provide these services to people in their communities?
Yeah, so we actually have a mentorship part of the program set up, and we're actually matching these students with experienced brokers that are located throughout the state. But that way they get this, they get 3 months of hands-on experience with an experienced broker before they they actually start.
Awesome. Thank you.
No problem. Thank you, John. Any other questions? All right, so we can move on to the next slide. I promise I'm almost done talking. So wrapping up here, I wanted to just include some very broad goals for the committee. I know James touched on some of this earlier. Of course, core to our mission, we want to reduce the rate of the uninsured and reduce health disparities, right? Thinking about ways to improve consumer access to health insurance, especially in underserved communities and neighborhoods that have significantly higher uninsured rates, right, compared to the state average. That will be a huge focus. And this will include a lot of different topics, right? This may include changes to the website or more education for consumers or getting more organization involved in our certified application counselor program, right? So they can enroll individuals at their organization. So that will be a really important focus, I think, for us. But the other two areas are very much related. We always want to expand our partnerships with community organizations. Collaboration is a key focus for health equity. As you all know, we get more done and we make a bigger impact together. And we've noticed that a lot of organizations are striving towards the same goal. So getting us together with organizations that are looking to achieve the same things will help us have a bigger impact. And then our outreach efforts, right? We want to always increase that, but we want to make it more meaningful as we move forward. The outreach team has been doing a fantastic job making connections, attending events in high need areas. But how do we build on that? How do we collaborate more with community organizations and the programs that they have going on? So these are just a few ideas from my perspective. I think it will be important for us to focus on as we move forward. But I was waiting for our first meeting before making any additions or any changes. I think input will be extremely valuable as we move and we build a strategic plan. So again, thank you, Ted, for reaching out to all of the members. We've received some really good feedback and suggestions already. So we'll include those on the future agenda, the future meeting agendas. One suggestion that was brought up, and I think it would be good to share today, was looking at the committee membership makeup, assessing if we need more people from different industries. I think we're a pretty well-rounded group, but depending on how the other committee members feel, that could be something that we look at as well, adding more people into the mix. So I'll pause here and I'll open it up for any discussions.
Just want to add a couple of comments that, we're very fortunate to live in Connecticut, where we have a state that is dedicated, work very hard at achieving our core mission at Access Health of lowering the uninsured and addressing health disparities. Because of those efforts and commitment of a number of organizations, our state legislature, we have one of the lowest uninsured rates in the country, right? Far lower than the national average. Unfortunately, the people who are still uninsured are the hardest to reach. Right? We know traditional marketing doesn't work. So this is why we created this new entity within Access Health to go into the community, to have a presence, an in-person presence, to engage with the communities, to give people access to health insurance, because we got to go there and be present and talk with them. Booker Academy is part of that strategy. So as Tammy indicated, we're going to have a more community-based approach to make sure that we are part of the community to inform and encourage people to enroll, get access to health insurance. And also a lot of folks in that 5.4, 5.5%, they believe health insurance is too expensive for them. but many of them, it'll be free of charge. Or very, very affordable because of all of the APTCs available, as well as Cover Connecticut, as well as Medicaid. But when they read in newspapers how expensive health insurance is, they don't even bother applying because they think it's unaffordable. So we have to go and convince them. And also the benefits of having health insurance, all those preventative services that at no cost to you. So again, a lot of education, a lot of access to information, and this is why the Boca County is a critical part of our strategy. So again, this going forward is going to be more being in the community, engaging with the community, making sure that they're aware about what's available and how affordable health insurance is to them. Again, this is going to be an ongoing struggle, but we are up to the challenge. Okay, thank you.
Okay, so great. Thanks so much, Tammy and James, for all that. As Tammy referenced, and you each know, I had a one-on-one with each of you. I tried to digest the points that came out of that and transmit them to the staff. And there's one that Tammy mentioned that I do want to invite discussion on, which is I know some folks have interest in discussion if we have the right members, whether we need to add members. So I want to have that discussion in just a moment. The other one thing I just want to put out there, and there's a number of really key important things that came out of those discussions that I won't touch on today, but we may in future meetings. But one thing that came out of it that was important, and I want to reiterate it and express it to kind of lay down a marker for this committee and for the staff that's supporting our efforts, is there was definite interest in establishing a culture here of using this committee as a sounding board before ideas are fully baked. In other words, the committee members don't seem to have much of an interest in rubber stamping fully formed or close to fully formed ideas, but rather would hope to be involved early in the formulation of next strategies. So I think that's a terrific goal and a terrific approach. And I did want to highlight that and make sure the committee members and the staff members knew that that was in the lifeblood and in the DNA of this committee. But with that comment, I will, following Tammy's lead, pick out the one thing that we wanted to discuss that came up, which is I know folks out there might have ideas about how to better round out this committee, areas of the community that aren't represented. So I know some of you have some ideas, and if you want to go ahead and address that, please do so now.
Ted, would it be okay to ask a question?
Absolutely,
Rather than
please.
just proposing ideas. I'm wondering, I love this set of goals, and I'm wondering how much coordination there is or you're anticipating there being with the Department of Insurance and Medicaid, particularly with the public health emergency unwinding, but also thinking about all of the dramatic changes in our health insurance systems over the last few years, like everything from Covered Connecticut coming on the scene to the No Surprises Act and other kind of federal regulatory changes that have happened. There's been a lot of concern that we're putting a lot of burden on consumers to understand how their health insurance works. And even those of us who do this for a living don't necessarily understand how our health insurance works. So I'm just wondering, if you've already kind of taken those steps to collaborate with DOI and Medicaid, as there's a lot of overlap and sort of population-wide concerns about not just affordability and the enrollment process, but also, whether or not bills are correct and how to get financial assistance and what people are entitled to and what their benefits are and all of that detailed stuff.
Okay, but before you jump in, James, let me just level set for the folks. that many of you folks know what Karen it meant when she was talking about unwinding and redetermination, but just to make sure. So during the public health emergency that was caused by the COVID situation, essentially Medicaid had a one-way street in. You could get in, but then there was not the periodic process to assess whether you were still eligible. And as a result, there's been a one-way trip into Medicaid, and some folks are on Medicaid that might not still be eligible. There's estimates that there might be 15 million people around the country. If Connecticut has its usual 1% amount, that's 150,000 folks in Connecticut that might be looking at some type of change. And so the question is how to do that in a way that's least stressful for everybody and allows folks to not just simply get kicked off of Medicaid, but understand that they might have an option, for instance, to land in a QHP, a qualified health plan with Access Health. And so Karen's question is, how closely is Access Health, or part of Karen's question is, how closely is Access Health coordinating with DSS, the Department of Social Services, and CID, the Connecticut Insurance Department, on this coming redetermination, which will happen over a 12-month period after the public health emergency gets concluded. Just wanted to make sure everybody had that background. But I cut you off, James. Please go ahead.
Thank you, Ted. Karen, let me give you a real situation that we deal with every day on a regular basis when we do redeterminations for Medicaid. We do a lot of advanced. First and foremost, both the Commissioner of Insurance and the and Dr. Gifford, who heads up DSS, both of them are on our board. We work intimately with DSS on a regular basis because they are one of our partners. We do a lot of operational functions with DSS. Our call center is a joint call center between us and DSS. So we have ongoing real operational functions between us and DSS. So the connection with DSS is real. And again, that's an ongoing relationship. So we have been discussing with DSS, planning with DSS, strategizing with DSS about the end of PHE and started. So we think we're well positioned to work collaboratively with DSS. We also have kept our board informed as to what we're doing, and Susan is going to go over the PHE process that we have been developing with DSS over the last 2.5 years. So I hope that it gives them some comfort that there's a strategy, there's communication, collaboration going on to minimize impact to Connecticut residents who may lose Medicaid. But the real example I want to share with you and the whole committee, and that we've dealt with at Access Health, Access Health is the place where for access to Medicaid. Our application process, you come to us. If you don't qualify for Medicaid, then you stay with Access Health. Otherwise, we pass you on to the DSS to enroll in Medicaid. We have had situations where we are Medicaid recipient tend to be more transient than most Connecticut residents. So the addresses change on a regular basis. So in spite of our best effort to communicate with them on a regular basis, they miss the opportunity to re-enroll. And often some Medicaid recipients may be on a maintenance drug to manage their health. And they find out that they don't have Medicaid when they go to refill that maintenance drug at the pharmacy. We've gotten calls because the pharmacy will reject the prescription, the renewal to renew the prescription, and because they're on Medicaid, and we get a call from the pharmacy, from the Medicaid recipient from the pharmacy, and we're on the phone with them to try to get resolved, while at least getting 10 days of coverage of medication. Then we'll work with DSS and then to resolve the issue for them. So we are working very hard to avoid those situations because for some of the folks, it's a life and death situation for them. So we are well aware the risk, the impact having individuals falling through the cracks because of lack of communication, and also they have no idea that they've lost Medicaid until they go see a doctor or go to a pharmacy. So we've been through that a number of times, and when they call us, we resolve it with them in the pharmacy and DSS, and then sometimes we have all four of us on the phone together getting resolved, and we don't get off the phone until the person has medication to address their health concerns. So that's what drives us every day, to minimize impact to this vulnerable population, where because of where they are, who they are, they may die because they don't have access to health insurance. That's a big part of our thought process that drives everything that we do every day. So we've been through it. We've been on the phone with them to make sure that doesn't happen. So we're doing a lot of advanced planning to minimize the risk of that happening to any Connecticut residents. And right now we have almost 400,000 folks who are part of the PHE. When we start redetermining, I think the term indicated of TED, we're going to stretch it over a 12-month period to minimize disruption, not just to the customers, but also to our operations, right, across the entire state, ESS and Access Health. So when Susan gets into our planning for the PHE, you will get more detail of our strategy and preparation for the end of PHE. I hope that was helpful, at least to our thought process in servicing this population.
That is really helpful, and I appreciate that. And I think part of what I was trying to say, not very articulately, was I think there's a lot of opportunity to build on the work that's been done around the end of the PHE, to work through community partnerships, to work through outreach, to make sure that people have access to not necessarily memorizing all the information about how insurance benefits work, but have access to people who they trust, who can answer their questions and help them deal with unexpected bills or losses of service, or you know, a number of the problems that you were talking about. So I do appreciate and commend the Access Health for all of the work that's been done to this point. I'm thinking that there may be additional opportunities for collaboration and coordination, you know, in perpetuity, not just around this particular very disruptive event. And I think that's something we could potentially talk about in this space in much more detail, if that's something you all are open to.
Absolutely. And Karen, you speak in our language, because the whole purpose of creating the new department within Access Health of the outreach, health equity and outreach, is to address those gaps that you just spoke about. And again, we need to have a presence in the communities, physical presence, to engage with the community that historically have been ignored, and lack of access to insurance, lack of access to information. And again, going back to the Broker Academy, was designed to plug some of those holes.
Yeah, James, I just wanted to, add to the question that was asked. We've been working very closely with Access Health. We have monthly meetings. I have Susan on speed dial. I have several people on speed dial to work through these issues, along with the Office of Healthcare Advocate. And I think over the years, we've created a very good working relationship. I think in the very beginning, we, and I'm talking years and years ago, where we ran into technology issues and there were a lot of bumps in the road. And I think, those lessons will serve us very well for these, pain points of large issues coming up. And I think we've learned how to collaboratively work and help consumers. And I think, again, my main reason for coming to these meetings and all the working groups that I'm in is to, let people who are out there in the community know to contact us, and the insurance department get the person in the right hands. There is no wrong door. We'll get them in the right hands, and we'll get to the bottom of the issues that people are having, working with Access Health, working with the Office of Healthcare, and working with DSS as well.
Great. And just to remind folks, Gerard is the head of the consumer assistance portion over at Insurance Department. So appreciate those comments there. Anything further from staff on that before we go to Sheldon? Okay, go ahead, Sheldon.
Hi, thanks, Ted. A couple things. One, I'm sorry to do this, but a little bit of a correction, which is that during the public health emergency, at least on the DSS side, and I think it's the same on the Access Health side, it's not that they aren't doing the redeterminations. They are. Like people, on Husky C particularly, get letters saying we're doing the redetermination, and actually the letter says you got to do it. You must do it. The difference is that during the public health emergency, they're not actually terminated if they don't do it. So, or they submit documents which show they're not eligible. They kept on. Footnote, as I think some of you know, we have a class action lawsuit pending against HHS because, in fact, not everybody is being kept on. There are certain categories of people, including non-citizens subject to the 5-year bar who were pregnant or are no longer 21, who are actually being cut off from Medicaid during it. So there was a lawsuit about that. But in any event, it is going to end eventually. And the real worry, I think, well, there's a lot of worries, Karen is absolutely right in laying that out, is the 42%. That's a statistic that was presented to the Medical Assistance Program Oversight Council on September 9th. 42% of the MAGI population, which includes Husky B, not Medicaid, mostly Medicaid, is on because of the public health emergency, not because they did the redetermination, were found to be eligible and kept on, but rather they are kept on anyway. So I appreciate everything that was just said about the efforts being made and the connections, but I think that Karen was really right about, engaging with advocates and consumers about how to reach people during this period. This is going to be an intense, if it's 42% that were kept on despite being found to be ineligible or not doing the paperwork, that's a really huge group. So one of the challenges, I think, and we have advocates have suggested this on the Medicaid side at the MAPOC meetings, is that we have to address the complacency that makes sense. It makes sense that people are complacent, that you sort of stay on anyway. If you don't do what you're supposed to do or whatever, you stay on anyway. So it's going to be a really huge lift. And I think I agree that this group could be a good place for input on how to do the outreach to try to minimize, 42% losing Medicaid. Most of those people probably still are eligible, right? But they're, things have changed. They didn't do the paperwork, whatever. Thank you.
Important correction and important comment. Sheldon, as folks might know, is one of the not just Connecticut but national experts on Medicaid. So we're really, really fortunate to have him here. Does anybody else have a comment or question in this area? Okay. Again, opening the floor, if anybody wants to have raise questions, comments, suggestions about our membership, please go ahead. And if you don't do it now, that's not your only opportunity. Of course, my door is open, staff door is open to any suggestions for new members.
So I'll chime in, and for the folks on the phone, this is Deb Poland. I originally got invited to join this committee when I was with the Community Health Center Association of Connecticut, and while I have moved on, I do think it's worth having somebody on this committee from that group. So that would be a recommendation. They do a lot of enrollment.
Yes, so to add to that, they're actually one of our navigators this year. So we are working very closely with them, particularly Sarah Lemaster. So yes, that's a very good. They have a majority of our CACs, if I'm not mistaken, and we work very closely with them on outreach efforts. Great, very good suggestion.
I know in my private meetings, a couple of folks raised an interest in whether or not it'd be feasible to try to get folks who are enrolled in a QHP onto this committee. Any thoughts on that from staff or committee members?
So Ted, we welcome the opportunity to engage with our customers, and I'll work with John Carbone to work with our brokers to recruit several QHP purchases so that we have the consumer viewpoint on the way forward. So we'll come back to the committee with some options as we move forward.
Great, thanks, James. Anything else in this area? If not, Tammy, if you want to direct us to the next area, go ahead.
Yes, Susan will be covering the next few slides, so I'll let her take it away.
Thank you, Tammy. Susan Rich-Bai, Director of Legal and Governmental Affairs. So first, we wanted to talk a little bit about essential community providers Tammy mentioned before, and it really ties in with this area of health equity and what this committee is focused on. So an essential community provider serves predominantly low-income, medically underserved individuals, and there are different types of providers that are included in this group, specifically federally qualified health centers, and there are many others that fall into it. So under the ACA, the carriers are required to meet specific standards for network adequacy for all of the providers in their provider network, including essential community providers within their provider networks. And here at Access Health, we've actually always had a higher standard than the FFM has had. So in the beginning of time, I think we may have had a 75% standard, and over time, you know, in working with the carriers, there were challenges in trying to meet that. So I believe the current standard of 50% has been in place since 2017. And what the requirement is that they contract with 50% of the federally qualified health centers and also 50% of the non-federally qualified health center providers on the Access Health ECP list. So another important aspect that Access Health has done that I don't know if all states have done is we have invested a lot over the years in creating this ECP list for the providers to make it easier for them to then go out and contract with these providers to meet the standards. So we do work all year. You know, we did a lot of work in the beginning of the exchange to create these lists, and we do a lot of work every year to keep them updated. And then we check in with the carriers twice a year. We provide them the updates to the list, and we do a check-in with them twice a year to see where they are, to make sure that they are meeting the standard. And if they're having any challenges, obviously to work with them, you know, on helping them to meet these standards. You know, they have told us there are some challenges. Some of these providers, community health centers, and some of these other types of providers, they can even go to school-based health centers. They're not used to dealing with a commercial carrier and a provider network. A lot of them predominantly accept payment from Medicaid. So for them, it's a whole different experience to be contracted and be in a commercial network. But the carriers have worked very hard over the years to get these community providers in the network. And the real purpose of all of this is that as consumers' income may change and they may move on and off Medicaid into various programs, that they can have the continuity with the provider that they've been seeing or their family members have been seeing, so they don't have to go change and go find a new doctor. So it's really vitally important. It really ties into the health equity focus and what we're talking about a lot with this committee. So if you want to go, I don't know if anyone has any questions.
Yes, Susan, if I could just level set a little bit for folks on the committee. So Susan mentioned the FM, that's the federal marketplace. Some states go through CMS, the Centers for Medicare and Medicaid Services, to handle their marketplace. Connecticut from the start has had a very successful state-based marketplace, or SBM, and that's Access Health. And just wanted folks to get a little bit of a flavor for some of the jargon that you're going to start to hear because we are in the marketplace arena. But with that, go ahead, Susan.
Thank you, Ted. If you go to the next slide, Marcin. So another important topic, obviously, of great importance to everyone here on the committee, is the public health emergency. So we have an update for you on that as well. So, and I think when I did this slide, there were 390,000. I checked this morning and we're just a little over 400,000 individuals are currently on the extended Husky coverage at this point in time. The expectation for the cycle of the public health emergency announcements that come out from U.S. Health and Human Services, they announce it with 90-day extensions. The current period that we're in will expire in the middle of October, and they have told states that they will give us 60 days notice before the public health emergency is going to end. So we know it's not going to end in October. So it is expected that it will be renewed in mid-October, and it'll be another 90-day period. And then it may end, that would put us into mid-January, so it may very well end at that point. So as we've been talking about, a lot of the focus is on the Medicaid extensions. Also, just to take a step outside of that for 1 second, Access Health has also continued to delay action on any verification requirements for QHP customers during the public health emergency. We continue to send them the notices to verify. Obviously, income is especially important for someone getting financial assistance with a QHP because they've got a tax credit with the IRS there. So we want to make sure consumers have their income updated, but we're not taking any action to take away the tax credits or that would impact their coverage. But that also is going to come to an end at some point when the public health emergency does end. So going back to Medicaid, as James mentioned, we've been working extremely closely with the Department of Social Services since the beginning of the public health emergency. Also with our, IT vendors, we have actions that need to be taken in the system pretty much every month or on a 3-month period. So we're continuing to be on top of that. And when it does end, we will go back to, the regular cycle of the redeterminations. We have been planning for a long time too on that schedule. Ted and James have mentioned 12 months. That is what we're permitted. The state plans to take the full 12 months and working closely to really determine the number of people that will be subject to the redeterminations each month and who goes first, who goes last. All of that planning has been going on in place, and obviously working to make sure that consumer focused first, but also for Access Health and the Department of Social Services. So another item here is because consumers have not been subject to redetermination during this period, many people have not touched their applications in a very long time. And as James mentioned, this population tends to be more transient. So we've all been very concerned about making sure that we have the most up-to-date contact information for people so that we can reach out to them with the redetermination notices and all of the communication efforts that are going to go on. So we have been working a lot, Tammy, with our community partners and navigators and others to get the message out for people to come in, even though they're not being redetermined yet, to contact us and come in and check with us and make sure that we have their up-to-date contact information so that we can reach them with that important information. And we're even tying it to some of our marketing and TV ad buys and other outreach into communities where we know there are large numbers of people that are going to be part of this effort to make sure that people are getting the message that, hey, you need to come in and check and make sure we have your contact information. So we've been working really closely on that. And then just also making sure that we are ready. As James mentioned, we have a joint call center. There's going to be a very increased volume of calls that are going to be coming into the call center once this starts. We've got the call center ready to keep the staff in place even after our annual open enrollment period ends so that we are ready and prepared, to meet the needs of everybody who's going through this redetermination process. And working close, Karen Siegel's organization and a number of others and OHS, we've had, a lot of meetings over the last several months or years also, just to get that community connection as well, so that we can maximize everybody's efforts here. So if there are any questions, or we can go slide.
Susan, we're also working with the carriers as well.
Yes.
The carriers are
Yes.
part of the overall effort. Because historically, a percentage of the 400,000 student talk will be redetermined to be QHP, not eligible for Medicaid. So we got to get them health insurance as well to avoid any type of disruption or gap in coverage for them. Again, we don't want anyone to find out that they don't have health insurance when they need services. All right.
And the new brokers from the Broker Academy will also,
Be a big part
go
of
a
that.
long way and be a big part of that effort as well.
Yeah, I
Susan,
almost wonder, oh, sorry, go ahead, Ted.
Sorry, Deb, but before we go on, I just wanted folks to note that earlier this week, President Biden did make a comment that the pandemic is over. I don't think that was a very well considered comment, but he is the head of the federal government, so it is very possible that this thing could be coming to a close early in 2023. But just wanted to add that. I think Deb was trying to get in. Go ahead.
Yeah, sorry about that. I think all of these efforts are going to be really important, and particularly working with trusted community providers. I also wonder, James, when you mentioned having the carriers also convey the information. I mean, I think if I received a letter in the mail from Access Health, I might think it was junk mail. But if I received a letter in the mail from my health insurance carrier, I would definitely open it. And so it might be worthwhile to see if they would be willing to send some of your communication in their envelopes, with their own communication on top of it. But I just wonder if others are like me and might be more apt to open an envelope from there, especially for the folks who are on the QHPs right now, or even the Husky folks, to open an envelope from Husky. They might be willing to do that.
So we are working very closely and collaboratively with both carriers. Communications is always the most effective way to minimize gap in coverage. Mm-hmm. So we will look at every option available to us to get the message out.
We do work on using
Question about that.
colored envelopes, using
Yeah.
and maybe and having the department's logo on things as well. Yeah, we really work closely with them on all of that to try to maximize people opening the envelopes.
Go ahead, Sheldon.
Sheldon, yeah. So the thing that's confusing to me though is that if somebody is actually losing Medicaid and they're eligible for QHP, you can't have a specific carrier send them a letter yet because they haven't signed up, right? So it can't be. I mean, I agree with Deb that she's right about that. People are more likely to open those letters. So that'd be great, but I just think it won't work here practically. Yeah. So maybe the Husky logo is better. I'm not sure, but I agree with this concern. It's really important. It's just unfortunate. I think that you can't have a letter coming from an insurer at that point because we don't have the insurer chosen yet.
Right.
Yeah,
There's
that is what I meant, actually. I'm so
there's-
sorry.
There's
Thanks
no
for,
relationship yet. Yeah.
yeah, thanks for clarifying.
Sheldon, you're right. It's when the insurers start sending information out, it gets really dicey because you talk about trust. So we are concerned about people confusing us with the insurers. So again, we're going to look at every option available to us, and we want to minimize confusion for the customers, and we want them to take action on their own behalf. So everything is on the table, but Sheldon, your point is well made about the insurers sending out our information under there. So we're concerned about that as well.
Yeah.
So again, everything is on the table. Again, we're looking at every option available to us to ensure that our the folks who are coming off PHE take action. That's our goal.
Yeah, obviously a very difficult communication situation when people have for the past 2 years gotten information about termination that turns out not to affect their life. So very difficult situation. Go ahead, Susan.
Oh, no, thank you, Ted. So if you want to go to the next slide, we'll actually come to another topic that will help in this area and hopefully help provide a soft landing place for some of those people that are no longer eligible for Medicaid. The state of Connecticut in 2021 created a wonderful program called the Covered Connecticut Program, and it is for adults who are ineligible for Medicaid for purposes of income up to 175% of the federal poverty level. And this program provides no cost coverage for those eligible consumers. They do not pay the consumer portion of premium. They enroll through Access Health in a qualified health plan, in a silver plan, a cost sharing reduction plan at that income level, which is terrific. And then the state pays the consumer portion of premium directly to the carrier and also pays the cost sharing amounts directly to the carrier. So people get a card from the carrier once they enroll in Covered Connecticut, and when they go to the provider, to the pharmacy, there is no cost sharing asked of them, you know, on the front end. And the program also provides dental and non-emergency medical transportation benefits, and those are actually provided through the Department of Social Services. So the enrollment is through Access Health. They are enrolling in a qualified health plan and enrolling into Covered Connecticut. And then the program itself is administered now by the Department of Social Services. It was originally by OHS, and it's been moved, the administration, to the department. And the state has applied, I'm sure most or some of you have heard, the state has applied for a Section 1115 waiver from the federal government to get federal matching for the state portion. I believe they're still waiting to hear. I haven't heard anything on that, but hopefully we'll be getting some good news on that. So as of now, there are 11,719 people enrolled in Covered Connecticut. I checked today's report. So that's really terrific. For the first year of the program, it was the people who are eligible were parents and caretakers up to that income level. And as of July of 22, it expanded to all adults up to that income level. So that's also really a terrific program that is out there, and hopefully will really bridge that gap for some people who, you know, once the public health emergency ends, are no longer eligible for Medicaid, but there is a continuing no cost option for them. So that's really good news, especially at this time. So we've been working a lot with all of our community partners and the department and OHS and everyone to get the word out, and the carriers, especially as James mentioned, to really get that word out to people, you know, in the community so they know that this is available. It's not just its name, Covered Connecticut, what it really means, what it really will mean for them.
Mr. Chairman, this concludes our presentation. We encourage any questions, comments, or concerns. Happy to answer them, but also after the meeting ends, we encourage you, if you have any questions about comments or suggestions, please email them to Martin. So he'll be the point of contact, gathering all of the information or question that you have, and we will follow up through him as well.
Okay. So Tammy, I see that we have a discussion item on future meeting cadence. Is that something you wanted to give us a recommendation on, or is that open for discussion? Please go ahead with that.
James, I think.
Sure. Mr. Chairman, folks, we're interested to get the committee's input about how often do you want to meet? Could be a monthly, quarterly, every 2 months. Maybe certain times a year we meet a little bit more often. For example, when we are preparing, when we are developing the plans for the next open enrollment, might be time for us to meet a little bit more. And also, and when we start developing a strategy around, when we're executing strategy around the end of the public health emergency, maybe we send our reports to this committee on a regular basis to kind of give you updates on what we are doing and what the numbers look like to get your input. And from time to time, Tammy or myself may reach out to the committee to get suggestions that we are doing events. We have capacity to do more events. If you have any ideas or thoughts of where we should target certain events. But right now, what we are doing, we are using our community partners to identify where to go, but we're also using our internal data. Because we know based on our analytics, we know where the folks who are going to be most impacted live, by zip code. So that's how we develop our outreach strategy, as well as input from community-based organizations, our navigators. But we'll reach out to this committee as well to get your suggestions of where you think we should go. If we are going there already, great. If not, we will go there. The question is, how often do we want to meet? Again, this is a new committee. I'm thinking that maybe for the first 6 to 12 months, we meet on a more regular basis. Once we get established, maybe we can scale it back a little bit more.
Okay, so I'd invite thoughts on that. I also will say whatever cadence we decide on, my own experience is that the staff at Access Health is very responsive and open, and you are now, if you haven't been before, you're now on an important committee for the organization, and you should feel free to reach out to staffers or to myself in between meetings with questions, comments, concerns. But with that, I'll open up the floor for any thoughts on meeting cadence. James, go ahead. I see Sheldon, were you raising your hand?
Yeah, I want to suggest, I think that, not to belabor the point, but the PHE unwinding is really huge. And it's sort of like we don't know when it's going to be, notwithstanding the comment by the president the other day. We don't know when it's going to end. If we do know for a fact it's going to end in January, which we will know mid-November, that's because of the 60-day thing, then I think that meeting every month really makes sense. I'm just wasn't entirely sure about that if it's not.
So Sheldon, we're certainly open to meeting on a monthly basis until we get established. Again, also with the end of PHE coming up, what we will do with this committee is share with you the strategy, the detailed strategy, what we're going to do and where we're going to do it, how we're going to do it, where we're going to go, what we're doing. We'll share that with you, and also share information as the strategy evolves and be executed. If we once we have data about how many people are being redetermined, how many are Medicaid, how many are QHP, we can share that with you as well. How many are more migrating to cover Connecticut? We will have all that data. We'll share with you, and then we will share with the committee also where we're going to go to do outreach, how we're doing outreach, and get your input, suggestions. So monthly meetings might be helpful as we prepare for end of PHE. That could be very helpful to us, and also informative to the committee to get your input.
Any thoughts on James' recommendation to start off with a monthly pattern? I think it's a good move, especially given the considerations that Sheldon raises, where we want to be ready. We don't want to have to add meetings on a hurry-up basis if all of a sudden we realize the PHE is going to end. So I think I'm without hearing anything else. I think that the recommendation that I'm hearing from the staff to start off monthly is amenable to the committee.
Sounds good.
Great. Okay, that brings us to adjournment. Marcin, do we need a roll call on that, or a motion and a roll call or not? Excuse me?
Yes, we do, Mr. Chair.
Okay, so I would first solicit a motion to adjourn. Can I have a motion?
So moved.
So moved by Deb Poland. Is there a second?
I second.
Second by Sheldon. It's not up for discussion since it's a motion to adjourn. Please go ahead with a roll call, Mr. Martin.
Theodore Dulro,
Aye.
Kevin Galvin, CC Woods,
Yes.
Karen Siegel,
Yes.
Giselle Carola McDonald,
Yes.
Leslie Greer,
Yes.
Deb Poland,
Yes.
and Charlotte Taban.
Yes.
Thank you.
Okay, well, let's adjourn the meeting then at 11:30. Thanks so much to staff and wonderful to convene. And I apologize for those in person that I wasn't there in person. I meant to be, and next time will be. Thanks so much, everybody.
Thank you.
Thank you.
Thank you.
Bye-bye.